Subscribe now and press the bell icon. Never miss an update.
Today's interactive session on diseases of stomach and the duodenum. Before starting the disease process, first we discuss about the anatomy of the stomach. So stomach is the most dilated part of the alimentary system, occupying the epigastric, left hypochondriac and umbilical region. So it is the most dilated part of the GI tract. The parts are fundus, body, pyloric antrum, pylorus. That means the part which lies that area, it is called the fundus. Then it is the body. There is the pyloric antrum, then pylorus. So these are the parts of stomach. There is two orifices, one orifice in the upper and another orifice in the lower end. The upper orifice is called the cardiac orifice and lower end orifice is called the pyloric orifice. So upper orifice is connected with the esophagus, lower orifice is connected with the duodenum. There is two curvature. This is the lesser curvature. This is the greater curvature of the stomach. And two surfaces, one in the anterior surface and an anterior superior surface, and another is behind, which is posterior inferior surface. And the whole stomach is covered by the peritoneum. So one thing remember, during development of the GI tract, it is a hollow tube in the midline. Subsequently, the developmental process, some parts of the intestine become dilated towards a lengthening. For the accommodation, they are having some rotation. So during the rotation, there is a stomach, the left side, it go into the anteriorly, and the right side go into the posteriorly. So for that reason, there is a vagus nerve, the right and left vagus. The left vagus go anteriorly, the right vagus go into posteriorly. So in the abdomen, it is called the anterior vagus and posterior vagus. So this is for the rotation of the stomach for that reasons. So arterial supply. The stomach having a rich blood supply. So where the rich blood supply, it is good luck for the patient and good luck for the surgeon, because easy to make an anastomosis, easy to heal. Whenever you do an anastomosis with any other part of the intestine, then easily can heal because there is rich blood supply for that reasons. So the stomach is supplied here from the celiac trunk, mainly supplied from the celiac trunk. So that celiac trunk is again supplied into the left gastric artery, and it is the splenic artery. And the common hepatic artery, it gives the branches of the right hepatic artery, then again go into the gastroduodenal artery. So this is the left gastric artery go up and arches and down. So this is the left gastric artery which supply the lower the esophagus and along the lesser curvature. The right gastric artery is supplied along the greater curvature of the stomach. So this anatomical course needs, because during surgical treatment, whenever you want to remove the whole stomach, so you can devascularize the stomach by dividing the arterial and veins. For that reason, this arterial supply must know everybody's. So the splenic artery, near that terminal end of the splenic artery, there is some branches which supply the stomach along the greater curvature near the fundus, which is called the short gastric vessels. And a great vessel go down from the splenic artery, which is called the left, from the left side, it go down, for that it is the left gastroepiploic artery. The gastroduodenal artery again divided into right gastroepiploic artery and superior pancreaticoduodenal artery. Superior pancreaticoduodenal artery. So that vessels can supply the whole of the stomach. So these are about the venous drainage. There is a corresponding artery, there is a vein. The vein drain, short gastric vein drain here, splenic vein. And again, the left gastrocolic gastromental vein go there, the splenic vein. Right gastromental vein go there. So these are the venous drainage correspond to the artery. There is a venous drainage there. So another important is the lymphatic drainage. So lymphatic drainage, everybody must know about the lymphatic drainage because that lymphatic drainage is important during the surgical treatment of malignant disease. Because whenever a patient having a cancer in the stomach or the GI tract, our main aim to remove the cancer site along with the normal proximal and distal side of the organ and block excision of the mesentery and along with the lymph nodes. So there is no remaining malignant cells there. So the patient becomes cured if you treat the patient earlier of the diseases. For that reason, the anatomical knowledge of the lymphatic drainage must know everybody. So the lymph vessels follow the arteries. It is a very important thing is the lymphatics runs along the arterial branches always. The main draining the lymph nodes lies at the root of the vessel, root of the artery. That means the stomach is supplied by the celiac trunk. So all the lymphatics ultimately drain into the root of the celiac trunk. So it is a basic conception is the lymphatics runs along with the artery because the artery having a pulsation which helps to propel the lymph from the small lymphatic vessels to the bigger one. For that reason, Allah Ta'ala made the body with this structure parallel and very close intimacy with the artery for that reason. So the lymph vessels follow the arteries into the left and right gastric nodes, the left and right gastroepithelial nodes and the short gastric nodes. That means first drain the lymphatics to the perigastric lymph nodes. That means the lymph nodes lies along the greater and lesser curvatures, along the vessels lies near the body of the, near the whole surface of the stomach. So first go there from that vicinity of the lymph nodes, then go on to the next branch, then ultimately drain to the celiac lymph nodes. So all lymph nodes from the stomach eventually passes to the celiac nodes located around the root of the celiac artery on the posterior abdominal wall. It is the final destinations of the lymphatic drainage to lymph node around the celiac tract. The lymphatics of the stomach are a considerable importance in the surgery of gastric cancer. During gastric cancer surgery, that lymphatic know the location, so you can easily excise the tissues and block with the malignant tissue and the lymphatics. So the curative treatment achieved if you do and block excision on that cases. There is a one nomenclature, gastric triangle. This is written in some books, not every book written there. So that knowledge needs to know, because if you don't know the gastric triangle, so you don't know able to put the gastrostomy tube. Because if you know the anatomical triangle, that area usually is free of other organ, so easily can put the stomach tube, gastrostomy tube percutaneously from the skin to the stomach. So for that reason, it is called the gastric triangle. That means it is the area of the stomach in contact with the anterior abdominal wall and presents the following boundaries. So look, this is the stomach. So on the right side and the up on the left side, there is the liver, right of the liver there. And below, there is a transverse colon usually lies there. And on the left side, it is a costal margin. So below the right costal margin, there is a liver down there. For that reason, the triangle is made by inferior margin of the liver, costal margin of the left side, costal margin, and there is a transverse colon. This is the triangle which is called the gastric triangle. So lower part of the liver on the right side, left costal margin on the left side, and transverse colon below. In complete esophageal obstructions, a tube is introduced in the stomach through the gastric triangle for feeding of the patient. Or not only the complete obstructions, but also in case of cerebrovascular accident, whenever the patient put the rice tube feedings, long time rice tube feeding needed, in that cases you can put a gastrostomy tube. So through this triangle, we can easily put the tubes into the stomach, which is called the feeding gastrostomy. So what about the duodenum? We are more oriented towards the stomach, not towards the duodenum. But the duodenum is very important part of the GI tract. It's having a course. The course is a curved, just like a C. And some part is ascending, some part is descending, some part runs transversely, and some part is ascending again. So this is the duodenum. This is the first part of the duodenum, then the second part, third part, and the fourth part. Our main important part is the second part, because that second part in the middle, there is an opening, which is the ampulla of Bader, where from above down to the common bile duct and transversely opening the pancreatic duct. So meeting together and make an opening there at the ampulla of Bader. So it is the main important site to drain the hepatobiliary and pancreatic juices there. So duodenum is the proximal part of the small intestine. It is subdivided into 4 parts. First part, second part, third part, and fourth part. So written there. The duodenum, except the first part, is devoid of mesentery. It is attached to the stomach. So stomach is covered by a mesentery, peritoneum. So it is also covered by the peritoneum. But here, the peritoneum is reflected in front of the duodenum, go laterally and go continuous the parietal wall. For that reason, the second part and third part is retroperitoneal organ. And is devoid of mesentery, retroperitoneal, and fixed. The proximal half of the upper part of the first part gives attachment to the free margin of the lesser omentum. So that proximal part is attached to the free margin of the lesser omentum. Yeah. The peculiarities of the first part includes it is the most movable part of the duodenum, as it is peritoneal attachment. It is supplied by end arteries, common site of peptic ulcer disease, devoid of circular mucous fold. A triangular radiopaque shadow is known as duodenal cap, or duodenal valve may be observed in the first part during perineal meal. The duodenal cap may be distorted in peptic ulcer or in malignant growth of the duodenum. The second part of the duodenum consists of the conical projection in the posterior middle wall called major duodenal papilla, in which the CVD and the main pancreatic duct units to form the ampulla of Bader, which opens here in the second part. What about the blood supply of the duodenum? So the stomach is supplied by the celiac trunk, but the duodenum is supplied by the branch of the celiac trunk and a branch of the superior mesenteric artery. So from below, it is inferior pancreatic duodenal artery. From above, the terminal branch of the gastrointestinal is superior pancreatic duodenal artery. So both the artery meeting together, arches forms and supply the duodenum. What are the diseases? So there are a lot of diseases. Among them, some are congenital, others are acquired. The congenital anomalies like infantile hypertrophic pyloric stenosis, congenital duodenal atresia, and duodenal web. There are 3 diseases can presented with like a gastric outlet obstruction presentations. The other are peptic ulcer disease. So peptic ulcer disease occurred in the stomach or in the duodenum or in the mucus diverticulum, etc. And others are gastric neoplasm, benign polyp or malignant on carcinoma, lymphoma, gastrointestinal stromal tumor, and carcinoid tumor. These are the malignant diseases. A benign may be gastric or duodenal polyp and duodenal neoplasm. So these are the diseases in the stomach and duodenum. What are the investigations we do for the diagnosis of gastric pathology? So for direct inspections, it is the best investigations to look inside the lumen of the stomach and duodenum. So the name of the investigation is called the endoscopy. So whenever we give the requisition for endoscopy, we write it there, endoscopy of the upper gastrointestinal tract. It means upper GI endoscopy. It is a flexible endoscope. Introduce into the esophagus mouth, through the mouth, go to the esophagus, and ultimately go to the stomach and duodenum. Look inside. So it is a gold standard investigations. It has both investigations diagnostic, or sometimes it takes some therapeutic purpose we can do by the endoscopy. The others are contrast X-ray. So that contrast X-ray is called the barium meal of the stomach and duodenum. So the barium meal is done, the barium sulfate powder mixed with water and mixed a mixture of the milk like liquid solution. That solution is ingested by the mouth and take the X-ray. Then it is called the barium meal X-ray of the stomach and duodenum. In comparison to the barium swallow, the swallow always ingests the paste, not the milk. It is semi-solid, so it can go slowly, easily take the X-ray, and good picture can take it. For that reasons, in case of esophageal pathology, we do the barium swallow. In case of stomach and duodenal pathology, we do the barium meal X-ray of the stomach and duodenum. Another one investigation is ultrasonography. But nowadays, the expertise are available, say they can detect some pathology of the stomach like congenital. So infantile hypertrophic pyloric stenosis, that disease can easily diagnosed by a good sonologist, do an ultrasonography. So external ultrasonography can be used for the stomach diseases and it's sensitive. And it is less sensitive. But important investigation for congenital hypertrophic pyloric stenosis. That can easily diagnosed by doing an ultrasonography. The other investigation like endoluminal ultrasound. It is a more sophisticated advanced ultrasonography. That means with the endoscope, there is a probe which go inside the stomach. From there, they directly take the picture in the wall of the stomach and the vicinity of the stomach. How many lymph nodes are around the stomach, they can easily look by endoluminal ultrasonography. So it is the investigation of choice for preoperative staging of the gastric cancer. CT scan and MRI, now these are mostly done, particularly CT scan for the carcinoma stomach staging. We can do the CT scan for visualization of the stomach size, stomach vicinity, lymph nodes, infiltration of the surrounding organs that can easily evaluate it by doing the CT scan or MRI. But for the stomach, we do the CT scan commonly. Another one is PET scan. This is positron emission tomography scan, which is helpful not only the carcinoma stomach, but also can diagnose the distal metastasis by doing the PET scan. But it is costly one. For that reason, routinely we not practice. But it is not available throughout the country. Only the Dhaka City 2 or 3 center can available there. So it is reserved for the money person only. So other investigation like is laparoscopy. Though the laparoscopy is invasive procedures, nowadays it is not done for the staging of the disease. It only done for therapeutic like surgical treatment or only done preoperative evaluation during operation. First do the laparoscopy, is it feasible for resectable or not? Only that cases. Gastric emptying studies. These studies is done for the diagnosis of disorder of the motility disorder of the stomach. Useful in the study of the gastric dysmotility problems, particularly following gastric surgery. Or the principal uses radioisotope level liquid and solid meals ingested by the patient and emptying the stomach is followed by a gamma camera. So this is our gastric emptying studies. Angiography, it is also an investigation protocol and also investigation for therapeutic approach also. It is commonly used in investigation of the upper GI bleeding when it is not diagnosed endoscopically. The bleeding point is not diagnosed endoscopically from the upper GI tract. In that case, we go for angiogram. So vascular angiogram done, the celiac trunk, the branches of the stomach supply can visualize and look there is any vascular bleeding site present or not. If there is any bleeding site is diagnosed during the angiography, at that time they can embolize the vessel with a detachable balloon or the coil, so block the artery supply, so arrest hemorrhage. So therapeutic embolization may be value in treatment of bleeding patients in whom the surgery is difficult or inadvisable. So upper GI endoscopy, also known as the esophagogastroduodenoscopy. So whenever you do the upper GI endoscopy, through the mouth you must go, that means through the esophagus you must go to the duodenum, stomach and duodenum. So esophagus can also be visualized. For that is also known as esophagogastroduodenoscopy. So diagnostic indications. So whenever the patient presents to a repeated attack of heartburn, not responding to the medical treatment, you can go for a heartburn, then go for diagnostic endoscopy. Is there any ulceration in the esophagus or the stomach or duodenum? You can diagnose. Is there any dysphagia or odynophagia? In that case, for differentiation of the diagnosis, must do an endoscopy. Or a patient having a hematemesis or the melena, so do the endoscopy. Is there any bleeding site or not? Persistent nausea and vomiting, in that case is needed to evaluate is there any obstruction or not. Whenever a patient with dyspepsia or upper abdominal pain not responding to the conservative treatment, then you do the evaluation, do an endoscopy. Unexplained weight loss or anemia, in that cases it is very important because some stomach malignancy, there is an ulceration there, chronic blood loss and causing the deterioration and lately diagnosed. So unexplained anemia, weight loss, you must do the endoscopy. And evaluation of abnormal barium meal X-ray. If do an barium meal, there is an abnormality seen in the stomach or the duodenum, for the confirmation, do an endoscopy. So therapeutic indications are, if the patient having hematemesis, do an endoscopy, there is a bleeding, so that bleeding vessels can arrest by a mechanical one or the laser or the phototherapy or the clipping. By any means, you can try to arrest hemorrhage. And sometimes the patient having a corrosive induced stricture or stenosis in the duodenum. So in that case, you can do a dilatation by endoscopic help. Removal of the foreign bodies, if anybody can ingest it accidentally or particularly the child, ingest a foreign body. So without laparotomy, you can remove it out with the endoscopic help by Dormia basket or by a foreign body forceps or by any net available in the market. They can throw it there and hold up and pull it out. Sometimes the patient having some polyps in the stomachs, so the polyp can divide, excised by endoscopy polypectomy and collect it and send for its pathological examination for confirmations. So some early cancer can treat by tumor ablation or by resection, submucosal resections. Percutaneous endoscopic gastrostomy PEG. It is very important tools, particularly in neuro patient. Whenever a patient has cerebral vascular accidents and there is a needed to a long time rise to fittings, you can avoid it by doing a percutaneous endoscopic gastrostomy. So what about the contraindications? The contraindications are, whenever a patient hemodynamically unstable, never ever go for endoscopy. Because if the patient is unconscious or semi-conscious, the patient does not respond to your command, and the patient may die due to the tongue fall back at that time. So hemodynamically, whenever unstable, it never ever go for endoscopy. So recent acute MI, don't go for endoscopy. Unstable angina or arrhythmia. Severe respiratory distress, don't go for endoscopy. Suspected perforations, don't go for. Or if any perforation, whenever you look the stomach during endoscopy, you can forcefully enter some airs and some fluid, water inside the stomach for clean the lens and distend the stomach and distend the mucosa and inspect the mucosa. For that is forcefully air introduced inside the stomach through the endoscope. For that reason, whenever a perforation, if you go to the endoscopy, so that increased pressure causing the increased size of the perforation and increased contamination of the peritoneal cavity more. If the patient is severe shock, so don't go for the endoscopy. Uncooperative patient. Some patient very uncooperative. They don't allow to put the airway tube in the mouth. So in that case, is a relative contraindication for upper GI endoscopy. So in that case of uncooperative patient, you can do it under giving the general anesthesia. That means after giving the anesthesia, you can do it. But rest of the cases, we usually practice that only the surface anesthesia, then we can examine the patient with upper GI endoscopy. But in case of uncooperative patient, the patient under anesthesia, you can evaluate it. So some picture there, the pictorial demonstrations. Look carefully. Whenever a bleeding vessel is exposed in the surface of the stomach or the duodenum, then the input some sclerosing agent by a needle through the endoscope at the site of the bleeding. So that sclerosion causing some thrombosis there and arrest tumoris. If the smaller vessels is there for in that case. Sometimes you can apply some diathermy, endocut diathermy, you can arrest tumoris. Sometimes in case of varicose of the esophageal varices, we can apply the varicose band ligations through the endoscope. Don't put your hand inside. From the exterior, you can easily put a band. The band is setting at the tip of the endoscope. From the outer end, you can easily manipulate, suck, and the pericell go inside the scope. Then put a band, so place there. So bleeding side of the vessel become compressed, so there is no bleeding there. Some through the endoscope apply directly lasers, so laser beam can arrest tumoris, or endoscopic clipping also available. It can easily put there 2 or 3 clips over the vessels, then can arrest tumoris. So in case of tumor, so laser ablations, or in a polyp, you can endoscopic polypectomy, or photodynamic therapy, or endoscopic submucosal resections. You resect the tumor along with some normal tissue on the mucosa, submucosal resections. In case of stricture, some benign or malignant strictures, you can able to dilate it with the balloon dilatation, or you can dilate with the rigid dilatations, or you can, after dilatation, for maintaining the long time effect, particularly in case of malignancy, you can put a stent there. So that stent can hold the growth of malignant tissues inside the lumen. So long time can passage of food materials from proximal to the distal and bypass the stricture site. So these are the therapeutic endoscopic pictorial demonstrations. What about the infantile hypertrophic pyloric stenosis? Look, the pylorus, there is a muscles there. So the muscle coat, whenever there is a hypertrophy, so in that cases, there is a spasm. So the food materials cannot pass from the stomach to the duodenum. So the baby can present it to you as a projectile vomiting. After feeding, there is a pain and projectile vomiting there. So it is a condition characterized by hypertrophy of the musculature of the pyloric antrum, resulting in constrictions and obstruction of the gastric outlet. It occurs between 2 to 8 weeks of age. It is only rarely often seen after 30 weeks. Characteristically, firstborn male infants are commonly affected. Firstborn male infants are commonly affected. So the clinical features are, look at the picture, there is a projectile vomiting there. So projectile forcible non-venous vomiting, it is characteristic one, non-venous, because the obstruction is proximal to the second part of the duodenum. So if the obstruction is distal to the second part, ampulla better, there is a chance to backflow of the bilious content to the stomach and migrate it with the vomitus. Then the vomitus is bilious vomitus. But here it is non-bilious because the obstruction is proximal to the duodenum for that reason. Immediately after vomiting, baby is often very hungry. Constipation is usually present, and when a stool is passed, it is small and dry. And the baby present to you is a loss of weight. But whenever you examine the baby, there is a visible peristalsis waves passing from left to right across the upper abdomen after the child has been fed. So left to right, there is a peristalsis. To overcome the obstruction, for that reason the peristalsis is visible. In relaxed baby, hypertrophy pylorus is palpable as olive-shaped mass in the right upper quadrant. And patient, look, the baby is dehydrated. So these are the presentations. What investigations? So investigation is, it is investigate the patient, baby with ultrasonography. Thickened pyloric muscle, if it is more or equal 4 millimeter, thickened pyloric muscle and length of the pyloric canal is more than 14 millimeter, then you suspect that the patient may have been congenital hypertrophic pyloric stenosis. In very young male, hugely distended stomach, a delayed gastric emptying, elongated narrowed pyloric canal, and contrast media cannot enter into the small intestine. These are the features of very young male X-ray. So in the exam, very frequently asked, particularly in the long case or in the OSP, what is the metabolic changes happen in case of gastric outlet obstructions? So if you read this page carefully, you can easily give the answer, and you understand. If you understand properly, you can easily give the answer. Otherwise, you don't able to give the answer. So the stomach having a capacity to produce hydrochloric acid. So the stomach is loaded with hydrochloric acid. So there is a gastric juice there. So there is a water there. Whenever a child or adult gets out obstruction with vomitus, so the vomitus can expel out the liquid portion of the stomach content. So it can expel out the gastric juices along with the food materials. So the water causing some dehydrations. And that gastric contents containing the electrolyte, that means acid, hydrogen ion and chloride are there. So the patient developed hypochloremic metabolic alkalosis. So loss of hydrogen ion and chloride causing hypochloremic metabolic alkalosis. But the body having a compensations, body having a capacity to compensate the electrolytes by the kidney mechanisms. So as a compensating mechanism, metabolic alkalosis, kidney excretes low chloride and more bicarbonate. So sodium is lost along with the bicarbonate there. So there is a hyponatremia and dehydration. Because of dehydration, there is again the sodium retention follows. Sodium is conserved in the exchange of potassium in the presence of aldosterone in the renal tubules, distal convoluted tubules. So when potassium is too low, whenever there is sodium is preserved, so the potassium is passes through the urine. So gradually the sodium potassium is declining. Whenever the potassium is too low, below the critical value, then the sodium is absorbed in exchange of hydrogen ion. Then the potassium is not available there. For that reason, they absorb sodium in exchange of release of hydrogen ion. For that reason, the patient developed hypokalemia, loss of potassium, and loss of hydrogen ion, causing the patient having paradoxical aciduria. Though the hydrogen ion loss in the vomitus, lately again there is a loss in the urine. For that reason, it is called paradoxical aciduria. So, in a nutshell, the patient developed dehydration, hypochloremic metabolic alkalosis, hyponatremia, hypokalemia, and paradoxical aciduria. These all terminology must know. Otherwise, we don't able to pass in the exam. What about the treatment? So, whenever a baby or the adult having gastric outlet obstructions, there is a vomitus, so chronic vomiting, so there is loss of fluid and electrolytes, so that must be need to correct it fast. So there is obstructions, you need to overcome the obstruction by any surgical means. So surgical treatment needed. For that reason, you need to prepare the stomach for surgery. For that reason, the patient put NPO, nil per mouth, or nil per oral, nasogastric suctions, IV fluid, correction of dehydration, and hypokalemic alkalosis. That means the baby is corrected with the saline. So in case of children, baby, you need to 150 to 180 ml per kg per day of 0.9% saline sodium chloride with 0.15% KCl potassium chloride in 5% glucose. That means 0.9% saline with 0.15% potassium chloride in 5% glucose. So this is the fluid regime for the child. Correct the electrolyte and fluid balance. Then go for surgical intervention. So in case of hypertrophic pyloric stenosis, that means the muscle become hypertrophy. So it causing the constriction of the lumen. So it causing the narrowing of the lumen. It can obstruct to flow of food materials from proximal to the distal side. So if you divide the constricted muscles, only the mucosa is left behind. So during passing the food materials, it can easily apart because the mucosa is bulged through the pylorotomy. With this aim, do the operation. The name of the operation is RAMSTEDTS operations. Pyloromyotomy is performed by laparoscopy or open supraumbilical incision. This is a medical emergency, but not surgical emergency. Because if you treat the surgical emergency, do the surgery without prepare the baby, the baby become die. For that reason, the term is written there. This is a medical emergency, but not the surgical emergency. What about the RAMSTEDTS operations? Look at the picture there. Serosal incision made from the pyloroduodenal junctions to the gastric antrum. The end result is intact bulging submucosa from the duodenal fornix to the gastric antrum. Great care is taken not to penetrate the mucosa. If you penetrate the mucosa, so there is a perforation. So be careful about it. An accident which is liable to occur while dividing the most distal part of the constricting fibers which are in the vicinity of the duodenal fornix. So be careful about the distal part, that area of the duodenal fornix side, because their constriction fiber is very adherent attached there. So for that reasons, be careful about not inside the mucosa, only the serous cord and the muscle cord divided. So this is called the RAMSTEDTS operations. Don't go for any stitches after opening the muscles. No, left it open, finish, nothing else. After doing the surgery, put a rice tube, inflate the stomach with the air and water, and look, and you apply some normal saline over there and observe is there any bubbling or not. If there is a bubbling, it indicates there is a perforation. So it is confirmed after surgery, there is no leak, then you suck the contents and close the abdomen. So in case of adult pyloric stenosis, though pyloric stenosis is a common infantile condition, but still it can occur in adults, it is a misnomer term. Commonly occurs as a complication due to long-standing chronic duodenal ulceritis. It may be mistaken for a carcinoma of the pylorus. When a diagnosis is made with certainly vagotomy, pyloroplasty, or a gastrostomy, gives excellent result. This is for adult pyloric stenosis. What about the gastritis? So the stomach always there needs to work. So you having some ingestion of the food. So the stomach is contracted, relaxation. So always there is a trauma. So gastritis is the inflammation of the gastric mucosa. So there is a chance of inflammation in the stomach. And always it is exposed to the acid content there. So the types are autoimmune gastritis and H. pylori gastritis. Autoimmune gastritis nowadays type A gastritis. It is an autoimmune condition in which there is circulating antibodies to the parietal cells. Circulating antibodies to the parietal cells. This results in atrophy of the parietal cell mass, hence hypochlorhydria and ultimately achlorhydria. So that autoantibody can block the parietal cell that prevent the release of acid into the stomach, which causing the gastritis. As intrinsic factor is produced by the parietal cells, there is a malabsorption of vitamin B12 leading to pernicious anemia. So the antrum is not affected. Very rarely may turn into the malignancy. H. pylori gastritis or type B gastritis affects the antrum, and these patients are prone to develop peptic ulcer disease. H. pylori associated pangastritis is also very common manifestation of infection. Patients with pangastritis seem to be more prone to development of gastric cancer. Patients with pangastritis seem to more prone to develop gastric cancer. So there is another a reflux gastritis. That means this is caused by enterogastric reflux, is particularly common after gastric surgery. It is occasionally found in patients with no previous surgical interventions or who have had a cholecystectomy. Bile chelating agents or prokinetic agents may be useful as a temporary measure to avoid revision of surgery. That means whenever the bilious content migrated into the stomach, so bile is causing there is irritation and causing gastritis, which is called the reflux gastritis. Erosive gastritis caused by agents that disturb gastric mucosal barrier like NSAID or alcohol, which can disturb the mucosal barrier. So there is a exposed to the acid to the mucosa and causing ulceration, which is called erosive gastritis. Stress gastritis. It is a common sequel of serious illness or injuries characterized by reduction in blood supply to superficial mucosa of the stomach. That means whenever the patient having a shock, so the visceral supply becomes constricted to supply the main to the heart and lungs and brain. So that can causing the mucosal vasoconstrictions and ultimately there is some sloughing in the gastritis. So which is called the stress gastritis. It can be prevented by routine use of H2 antagonist with or without barrier agent such as sucralfate in patients who are on intensive care unit. Other rare forms of gastritis, Meniere's disease, lymphocytic gastritis, eosinophilic gastritis, granulomatous gastritis. These are solely treated by the gastroenterologist. With the surgical people, we are don't worried about this gastritis. This is our chapter of surgical individual, peptic ulcer disease. So introduction. Peptic ulcers results from the corrosive action of the acid gastric juice on a vulnerable epithelium of the stomach. That means whenever the epithelium is exposed to the acid, there is a chance of ulcerations, which is called the peptic ulcers. So the site of the peptic ulcer, commonly in the first part of the duodenum, in the stomach, along the lesser curvature of the stomach, or lower end of the esophagus, at the stoma after gastrostomy, or mucus diverticulum. Because in the mucus diverticulum, sometimes having some ectopic gastric epithelium at the neck of the mucus. So that ectopic epithelium release of acid causing ulceration there. So that peptic ulcer may occur at the site of the Meckel's also. So etiological factors: infection with H. pylori, Helicobacter pylori, NSAID ingestion, cigarette smoking, alcohol consumption, sometimes having a gastrinoma, Zollinger-Ellison syndrome, and genetic factors. Peptic ulcer has been classified based on the location. In some Indian books written this types of classification: type 1, type 2, 3, 4, 5, etc. Commonly the type 1. That type 1 is location lesser curvature near the incisura, and acid level is low to normal. Type 2 is 25% gastric body with duodenal ulcer, increased. Acid release, acid level is increased. But type 3 is a pre-pyloric ulcer, and acid level also increased. But in case of type 4, high on lesser curvature near the gastric junction, here the acid content is normal. But type 5, anywhere in the stomach. So clinical features of duodenal ulcer and gastric ulcer. Age, usually in the 30 to 40 years of age, duodenal ulcer. In the gastric ulcer is the elderly age, 50 to 60 years of age. Sex more in male duodenal ulcer, gastric ulcer effect equally. Pain in the epigastric duodenal ulcer, in gastric ulcer epigastric, may radiate to the back. If particularly with the posterior gastric ulcer, in that is radiate to the back more. Periodicity of pain well marked in duodenal ulcer, gastric ulcer also present. But onset of pain 2 to 3 hours after eating and midnight. Whenever the stomach become empty, there is a feeling of pain more. Immediately after eating meal in gastric ulcer. Duration of pain long, gastric ulcer is short. Pain aggravated by hunger, pain aggravated by gastric ulcer. Eating, after eating the pain aggravate. Pain relieved by eating food, pain is lying down or vomiting, the pain is relieved. The vomiting is uncommon in case of duodenal ulcer. Vomiting is common, particularly in gastric ulcer. Appetite good, patient is afraid to eat in case of gastric ulcer. Weight loss, no weight loss. In case of gastric ulcer, there is weight loss. Hematemesis is uncommon, gastric ulcer is common. Melena may be common in case of duodenal ulcer. Gastric ulcer may not uncommon. Malignancy, never duodenal ulcer, but may turn into the malignancy in case of gastric ulcer. So what about the investigations? So only one investigation is sufficient to diagnose the ulcer is upper GI endoscopy. So investigation of choice, it allows direct visualization of the ulcer crater, take multiple biopsies from the ulcerated lesions, rapid urine test or CLO test, Campylobacter-like organism, done for tissue biopsies, done from the tissue biopsy. That means this is the endoscopy pictures. There is ulcerated lesions. The ulcer is covered by a slough. There is ulcerated lesions. There is no slough is there in case of duodenal ulcer. But in case of gastric ulcer, there is shown the picture that is covered with slough. It is in the first part of the duodenum. It is in the along the lesser curvature probably there. So barium mill X-ray in the gastric ulcer to see the niche, ulcer niche and notch. So there is ulceration niche there. In case of gastric, it may present as a notch. And duodenal ulcer shows the deformed and absence of duodenal cap. In a normal individual, the duodenum having a cap there, if you look in the X-ray, there is a cap, smooth cap there. But whenever there is an ulceration in the duodenal, first part of the duodenum, the ulcer causing scarring, and the scar become contracted and the deformity of the valve. For that reason, in case of duodenal ulcer, the valve is deformed. And ultrasonography to exclude differential diagnosis, not for diagnosis of the peptic ulcer disease, to exclude other diseases like head of the pancreas, lesions, etc. So test for H. pylori. So there is a endoscopy biopsy required. So after taking the biopsy tissues, rapid urase test, the tissue is submerging into the container. There is a specimen is sent rise there, and look, there is urase test is positive or negative. And the culture H. pylori from the biopsy. If available, you can do the culture for H. pylori. Non-invasive test, urea bread test. That means it utilizes the isotope and is based on ability of H. pylori to convert the urea to ammonia and carbon dioxide. That means you ingested some urea through the mouth, go to the stomach, so unchanged urea in the urine, ammonia is produced, bicarbonate is released, through the respiratory tract, it go out with the breath. So the breath is inhaled with a meter that can calculate what about there. So this is called the urea breath test. So what is the differentiation between the benign ulcer and the malignant ulcer? So the benign ulcer, round to oval punched out lesions with the straight walls and flat smooth base. But in case of malignant ulcer, irregular outline with necrotic or hemorrhagic base there. In case of benign ulcer, smooth margins with normal surrounding mucosa. In case of malignant ulcer, irregular and raised margin. Mostly on lesser curvature in the benign ulcer and malignant ulcer anywhere. Majority is less than 2 cm, but malignant ulcer any size. With the bigger ulcer, the more chance of malignancy rate high. Normal adjoining rugal folds that extends to the margin of the base. Prominent and edematous rugal folds that usually do not extend to the margins. So look the picture, it is a benign ulcer, it is a malignant ulcer, irregular in outline. So it is a benign gastric ulcer, smooth in outline, but there is irregular in the outline. So complication. Whenever there is an ulceration, so that ulcer causing erode the base, flow. So erosion of the base causing if the muscle cord eroded, if underlying the muscles there is a big vessels there, so that can causing the bleeding. If whenever the ulcer is more deepened, eroded the muscle cord, particularly in the entry wall of the duodenum. So whenever there is the entry wall of the duodenum is perforated, so there is no vessel in the surface, so the presentation is perforation of the hollow discus. So for that is an early complications of perforations, and late early some bleeding, some disease in the particular in the posterior ulcer of the duodenum presented with a bleeding, not the perforation. And late complication is pyloric stenosis, scarring causing obstructions, so gradual narrowing of the lumen causing gradual distension of the stomach, vomiting, so the patient presented with pyloric stenosis or gastric outlet obstructions. So these are the two is the same. Pyloric stenosis is a wrong nomenclature because there is no stenosis in the pylorus. The stenosis in the first part of the duodenum. So in case of benign, that means peptic ulcer disease due to chronic duodenal ulcer, whenever the outlet obstruction is occurred, then the diagnosis is called the pyloric stenosis. So though it is not the pylorus stenosis, the term is given due to the stenosis in the first part of the duodenum. When an anterior and posterior duodenal ulcer are present together, then it is termed as the kissing ulcer, because during giving the kiss needed to both the lip touches to each other. So for that reason, the ulcer is meeting together, anterior posterior wall, so the name is called the kissing ulcers. Anterior wall of the first part of the duodenum perforates due to the rush of gastric contents. It is very important thing is, whenever the food content is migrated from the stomach to the duodenum, by the forceful contraction of the stomach, the duodenal content is ejected out through the pylorus and directly it hits the anterior wall of the duodenum. So more concentration of the acid content is directly touches the anterior wall, then all the gastric juice migrated to the other parts of the wall of the duodenum. For that reason, anterior ulcer is more than the posterior ulcer. The posterior wall of the first part of the duodenum bleeds because due to the erosion of the wall, which is very close intimacy with the gastroduodenal artery. So whenever gradually ulcerations and erosion of the wall of the duodenum And ultimately, when the erosion of the wall of the gastroduodenal artery then can bleeds directly into the duodenum. So the patient present to you with hematemesis and a melena. For that reasons, the anterior ulcer perforate, posterior ulcer bleeds, because anterior ulcer there is no support other than peritoneum. So whenever the peritoneum is eroded, it directly communicates the lesser in the greater sac. So the free peritoneal cavity. So the presentation, exposure of the acid content in the peritoneal cavity, irritation of the body presented with a acute abdomen light, which the diagnosis is peritonitis. So perforation is presented anterior ulcer. So during the treatment, not only for the medication, but also not for the surgery, you also advise the patient to take some modification, lifestyle. It is very important thing. Otherwise, the disease is never cured. Life discontinues NSAID. Advise the patient, don't treat the pain with NSAID. If there is pain, you take the medication, the acetaminophen, the paracetamol, not more than stronger drugs take, because it's causing more irritation, more ulceration there. Smoking, definitely avoided it. Alcohol, cessation needed. Stress reduction. If there is stress less, so there is a more blood supply to the stomach, more cool the patient. So there is less chance of complication of peptic ulcer. Medical treatment. Anti-secretory drugs prescribed. We routinely practice a lot of the patients, but here the anti-secretory drugs are, one is H2 receptor blockers, another one is proton pump inhibitors. So H2 receptor antagonist, there is some ranitidine, famotidine, nizatidine. But ranitidine nowadays become obsolete because it having some carcinogenic proved. For that is a carcinogenic agent. For that reason, ranitidine is obsolete nowadays. Proton pump inhibitor is omeprazole, esomeprazole, lansoprazole, etc. So you treat the patient to decline the acid secretions, one, and simultaneously, if the patient, the cause of ulcer is due to the Helicobacter pylori, you need to treat the Helicobacter pylori. Otherwise, you don't kill the pylori, there is no scope to heal the ulcer. For that reason, H. pylori eradication therapy is needed for 10 to 14 days, drugs, triple therapy or quadruple therapy. Triple therapy included the proton pump inhibitors along with 2 antibodies, either metronidazole, clarithromycin, or amoxicillin. Quadruple therapy, proton pump inhibitor, bismuth, subsalicylate or subcyclate, metronidazole, tetracycline. These are the drugs to treat the H. pylori. What about the surgery? So the surgery operations for duodenal ulcer, the aim of the surgery is to exclude the damaging effect of the acid from the duodenum. This has been achieved by diversion of the acid away from the duodenum, reducing the secretory potential of the stomach or bone. So, in case of more surgical achievement of success treatment for peptic ulcer disease, duodenal ulcer disease, the main achievement done if you do the Billard 2 gastrectomy, that means if your antrum is divided and remove it out, then make an anastomosis with a vagotomy. So there is a chance of recurrent of the ulcer is less. But the morbidity is too high. For that reason, we don't practice it. We commonly practice is vagotomy with gastrojejunostomy. So we discuss about the operation for duodenal ulcer. These are all written in the Bellis and Love book. But for your exam, your answer is simple, which is called a truncal vagotomy with gastrojejunostomy. This is sufficient. Don't need for utter that all the names. Very simple answer is for duodenal ulcer disease, the treatment is, surgical treatment is vagotomy and gastrojejunostomy. So vagotomy and gastrojejunostomy, done not for the duodenal ulcer, for the complication of the duodenal ulcer. That means whenever the patient presents to you pyloric stenosis, vomiting, only in that cases we go for surgical treatment, like vagotomy and gastrostomy. Vagotomy means truncal vagotomy with gastrostomy. But these are the other options like Bilroth 2 gastrectomy, gastrostomy, vagotomy, enterectomy, pyloroplasty. These all are the options of duodenal ulcer disease treatment. Operation for gastric ulcer is with the duodenal ulcer surgery, when the principal objective was to reduce the duodenal acid exposure. In gastric ulceration, the diseased tissue is usually removed as well. So in case of gastric ulcer, the book is written there as a Bilroth 1 gastrectomy. Again, they are written there, this surgery is virtually never performed now. So the ultimate treatment is, it is only the conservative treatment. If the medical treatment is not responded, in that case, go for the surgical treatment. Otherwise, don't go for surgical treatment. So indication of surgery is failure of medical treatment, development of complication like bleeding peptic ulcer or perforation duodenal ulcer or gastric ulcer obstructions. Then go for the surgical treatment. Or repeated recurrences of treatment don't respond to the medical treatment. So what about the vagotomy? So whenever the vagus nerve is divided, it is called the vagotomy. So division of the vagus nerve to reduce the production of hydrochloric acid from the parietal cells in patients with peptic ulcer is called the vagotomy. So divide the vagus so the hydrochloric acid producing parietal cells is devoid of vagus nerve supply. So there is stimulation is not there. So there is a decrease the acid content release. Types are truncal vagotomy, selective vagotomy, and another one is highly selective vagotomy. But we routinely practice the truncal vagotomy. It is so easy to do it for that reason. It involves section of the main trunks of both vagus. That means anterior vagus and posterior vagus, we divide. So if we divide, so there is no vagus supply there. Patient may develop post-vagotomy diarrhea because of damage of the hepatic and celiac branches. As vagus nerve supply motor supply to the stomach, so there will be gastric stasis if drainage procedure is not performed. So whenever you do the vagotomy, always we do a drainage procedure. The drainage procedure may be pyloroplasty, that means Hennig-McCauley's pyloroplasty or gastrojejunostomy. Otherwise, there is a chance of stasis of food materials in the stomach. Don't go properly distally. Selective vagotomy. Selective means you divide the vagus, but you select some branches to preserve. That means those branches which supply the gallbladder. So for that reason, it is started with selective vagotomy. If you spare the hepatic branch, then there is a celiac branch, then there is a chance of less symptom like diarrhea, etc. For that reason, it is called the selective vagotomy. Here, vagotomy is done sparing the hepatic branch of the anterior vagus and the celiac branch of the posterior vagus. And drainage procedure is also performed because the enteral supply is divided, so don't properly drain. For that is a drainage procedure must be needed there in case of selective vagotomy, in case of truncal vagotomy. Time consuming, so it is now abandoned. Next one is highly selective vagotomy. So here, only the fibers entering the stomach that supply the acid producing oxygenating gland is divided both anteriorly and posteriorly. Nerve of letargius supplying the antrum is retained, so drainage procedure is not required. It is the gold standard operation for uncomplicated chronic duodenal ulcers. So look, whenever you divide at the trunk, all the branches are disconnected. It is called the truncal vagotomy. When you save the hepatic and the celiac branch, only divided here, so you disconnect the distal part, it is called the selective part. But whenever only the small branches supply that body, only there, so the trunk is remaining up to the nerve of letargius, they are preserved, so pylorus is supplied, it can easily empty. For that reason, it is called the highly selective. So select the small branches and divide it. So it is called highly selective product. So that nerve of lateral jet, it looks like a crow's foot. It is sometime in MCQ exam in the FCS part 1, the question is written there. Say the nerve of lateral jet, it looks like a crow's foot. So what about the drainage procedure? So drainage procedure, that means gastrojejunostomy. You anastomosis the stomach with the jejunum. So the food materials, instead of duodenum, they directly go to the jejunum, go distally. It is called the gastrojejunostomy. Allows food to bypass the obstructions. In case of henic Nicolis pyloroplasty, make a longitudinal incisions from the antrum to the duodenum. Then make a longitudinal incision and close transversely. So the diameter of the duodenum and the pyloric part is become increases, easily flow of food materials from the stomach to the duodenum. It is called henic Nicolis pyloroplasty. And in case of enterectomy, so the antrum is divided. So vagus is disconnected there. So for that reasons, drainage is needed. That means new anastomosis is made with the antrum and the not antrum with the body of the stomach with the duodenum. It is called the enterectomy and Billroth 1 gastroduodenostomy by gastroduodenostomy. So Billroth surgery having two types. One is type 1, another one is type 2. So the type 1 is you divide the antrum and the proximal and distal part is anastomosed to each others. So it is called the Billroth 1. It means gastroduodenostomy. In case of Billroth 2, the stomach antrum is divided. So the tissue is divided. The stump of the duodenum is closed and the stomach is anastomosed with the jejunum. It is called gastrojejunostomy, which is called the Billroth 2. Billroth 1, end-to-end anastomosis. Billroth 2, stomach with jejunum, not the duodenum. Then it is called the Billroth 2 surgery. So these are the two types of surgery in case of stomach. So look at the Billroth operation. Billroth 1 operation.
In the Billroth 1 operation, the distal stomach is anastomosed directly to the duodenum, end to end.
This is Billroth 1. What was it?
In the Billroth 2 operation, the proximal end of the duodenum is first closed. The distal stomach is then anastomosed to the proximal jejunum, normally end to side. Finally, a side-to-side anastomosis is made between the jejunum and distal duodenum to facilitate the supply of bile and pancreatic juice.
So that jejunojejunostomy not all the time done. If you do the jejunojejunostomy simultaneously, it is better because otherwise the bile is migrated through the upper end during migration, some reflux to the stomach. For that reason, sometimes during Billroth 2 operation, we do the jejunojejunostomy. So postbiotic complications. So complications are recurrent of ulceration, small stomach syndrome. Whenever divide the stomach is smaller in size. The bile vomiting, if the patient having gastrojejunostomy without jejunojejunostomy, so there is a bile is coming to the stomach. And early and late dumping syndrome, post-vagotomy diarrhea, malignant transformations, nutritional consequences, anemia due to vitamin B12 deficiency, osteoporosis in postmenopausal women, and some patient may present with lately gallstones. So dumping syndrome. That means there is two types of dumping syndrome. One is early dumping, another late dumping. Definition. It is consists of abdominal and vasomotor symptoms. That means abdominal pain, flushing of the face, etc. following gastrectomy or vagotomy and drainage. It is called early dumping syndrome. The carbohydrate load in the late dumping syndrome, load in the small bowel causes a rise in the plasma glucose level, which in turn causes insulin level to rise, causing secondary hypoglycemia. That means there is no sphincter. So easily can drain the food materials, go into the distal part of the jejunum. So there is an absorption of glucose more, carbohydrate food materials more. So the blood supply is rapidly, blood glucose rapidly rises, which causing release of insulin from the pancreas and causing secondary hypoglycemia, which is called the late dumping syndrome. Relation of the meals, it is almost immediately, and late dumping 2 hours after meal. Duration of attack is either 30 to 40 minutes, 2 hours after meal. Relieved by lying down, relieved by food. So if you're lying down, so there is a emptying is slow. For that reason, lying down is early dumping syndrome is slow, is less severe. Aggravated by more food, aggravated by exercise, and precipitating factors, food, especially carbohydrate rich and wet, as early dumping. Major symptoms like epigastric fullness, sweating, lightheadedness, tachycardia, colic pain, sometimes diarrhea. And there is a tremor, faintness, frustration like of hypoglycemic presentations. Treatment, dietary manipulation. It is a very important thing. Whenever you do the gastroenterostomy, always prescribe the patient during discharge. Don't take much amount of water during taking heavy meal. And small dry meals given, avoiding carbohydrate-rich food. Somatostatin analog, sometimes octreotide, before meals has been shown to be useful. And late dumping treated by giving glucose and food, octreotide is also effective. What about the perforated peptic ulcer? So perforated peptic ulcer, commonly the duodenal ulcer perforation happen. Gastric ulcer may be perforate. But whenever there is a perforation, so that means the gastric contents migrated to the peritoneal cavity. So the gastric contents rich of acid. So it causing directly touches the parietal peritoneum and the peritoneal cavity. So it is a burning the peritoneum by the acid content and causing inflammations. So the patient feels pain. For the body protections, there is a spasm of the muscles, they rigid the muscles, less mobility of the body. So localize, try to localize the pain for that aim. So the presentation is severe, sudden pain, sudden, severe, agonizing pain in the epigastric regions. Then the pain becomes generalized. Very important thing is. So whenever the anterior wall of the duodenum is perforated, so suddenly the gas of acid content migrated and directly hit the parietal peritoneum. So after touching the parietal peritoneum, the contents is migrated, trickled down through the gutter, right and left paracolic gutters or anterior abdominal wall, and ultimately go into the pelvic cavity. So the body defense mechanism, immediately whenever there is a pain, there is a nausea and vomiting. To prevent by defensive attitude, further input is held up. So no input, so less entrance into the abdomen, less distension of the stomach, less contamination. So body defense attitude presentation is nausea and vomiting at the simultaneous. So sign is patient is toxic with tachycardia, hypertension, and tachypnea if the patient lately present. Dehydration present whenever the patient present lately. Restricted abdominal movements with the respirations due to pain. Board-like rigidity of the abdomen. The abdomen, whenever you palpate, is board-like rigid. On percussion, percussion is hyperresonant and tympanic. Obliteration of the liver dumbness. On auscultation, bowel sound initially may be present, but later on may be absent, which indicates the patient lately developed paralytic ileus. Abdominal distension may be present lately. These are the clinical presentations. But that scenario development having some stages, that stages are classified into 3 stages. Initially, whenever the contamination directly with the acid content, it is called the stage of chemical peritonitis or peritonism. Once perforation occurs, stomach contents escape into the peritoneal cavity, the acid causes chemical peritonitis. In this stage, whenever there is peritonitis, there is inflammation, so there is exudations. So in this stage, the patient complains of severe pain in the epigastric region and vomiting. After some time, the patient, some development of reaction of the peritoneal cavity with the content. So it is called the stage of reaction or ileustion. That means in this stage, the peritoneal contaminated acid content become diluted by the exudations. So the peritoneum reacts to the chemical irritation by secreting large amount of peritoneal fluid to dilute this toxic fluid. So this gives relief of pain for short time. This lasts for 3 to 6 hours. And after that, the patient again feel pain due to the distension of the abdomen. There is a stage of diffuse bacterial peritonitis. After 6 hours, bacteria from the GI tract escape from the site of perforation, causing diffuse peritonitis and paralytic ileus, and distension of the abdomen develop. So what investigation of choice for diagnosis of perforated peptic ulcer? So only one investigation is sufficient: clinical history and one investigation. This investigation is simple X-ray chest in erect posture. Normally all the X-rays will be done in the X-ray chest is the erect posture, and plain X-ray cave in the lying posture, and plain X-ray abdomen in erect posture. But better to do an X-ray chest, because our main aim to visualize the undersurface of the diaphragm. Because if the undersurface of the diaphragm is not visualized properly, you don't able to diagnose is a free gas or not. Because whenever a patient is standing in posture, so the free gas is migrated up. So whenever it is migrated up, it becomes occupied the space between the diaphragm and the liver. So, or diaphragm of the fundus. So in that cases, there is a crescentic shadow with a black crescentic shadow look. It is diagnostic, right, that it is the free air in the peritoneal cavity. So plain X-ray chest in erect posture in showing both domes of the diaphragm, free gas shadow under the right dome or both domes of the diaphragm. Then your diagnostic confirmation is pneumoperitoneum is there. After taking the history, there is a pain, severe sudden pain, no other operation, etc. Then your diagnosis, it is perforated peptic ulcer most likely. And with the history of previous, the patient having history of long-standing pain in the epigastrium, the patient history of take of medication like H2 blockers, or the proton pump inhibitors, or along with the history of some NSAID or steroid drugs ingestion history may be present sometimes. So these are associated findings and confirm your diagnosis is patient having pneumoperitoneum. And ultrasound of the abdomen may show the collection. What about the collection of the peritoneal cavity? That are evaluated by the ultrasonography. By ultrasonography, it is very difficult to diagnose the perforation because air is the enemy for the ultrasonograph. And CT scan of the abdomen also. It is diagnostic tool. If available, you can do it. If the patient is solvent, they can do it. The CT scan can confirmatory to diagnose the patient having some pneumoperitoneum with perforation of hollow viscous there. Other investigation is needed to do the differentiation of other diseases like pancreatitis, etc. For that is a serum amylase is needed. Electrolyte, because the patient having vomiting, dehydration, so electrolyte imbalance present. So for correction, you must know the value of electrolytes. What is the normal value and what is the present value is. So by calculation, you can correct the electrolytes. What about the serum creatinine? Because if the patient needs surgical treatment, you must know the creatinine level and blood sugar level and complete blood count. So that complete blood count indicates the level of peritonitis bacterial infection. Whenever there is infection, there is a total count is also raised. So it is also a supporting treatment. What about the hemoglobin? Preoperative, you can assess by doing the CBC, complete blood count. And ECG is done because it is usually occur in the elderly, that is 30 years, 40 years, or 50 years. So before doing surgery, you must do the evaluation. For that reason, you do an ECG. But in case of X-ray chest, whenever the patient is able to standing, then do X-ray chest in erect posture. But whenever the patient is abdominally hugely distended, the patient is not capable to lying, capable to standing. In that case, you can do the X-ray in a lateral, plain X-ray abdomen lateral view. So in the lateral view, whenever the patient on the left lateral position, so the right lateral wall, right side of the abdominal wall is high up. So always gas is tendency to free gas go up. So if you examine carefully, then you look the right side of the, there is a liver and the diaphragm on the right lateral wall, there may be free gas there. So in that case, in case of moribund patient, or whenever the patient is not capable to standing, in that case, do an X-ray in a left lateral posture. Plain X-ray abdomen in left lateral position. Plain X-ray abdomen in left lateral position. Sometimes in advanced center, they also do some X-ray without lateral position. They do an X-ray in some tender lumbar position. So in that cases, the free gases go in the iliac fossa. In the iliac bone, there may be free gas there. So that position also can detect whenever the patient is not capable to stand in that case. So these are the alternative options. What about the treatment? So treatment is whenever there is a perforation, so don't go further injection. So stop, nail by mouth, and put in nasogastric tubes. Aspirate all the content of the stomach. So stomach is empty, no further contamination of the peritoneal cavity happen. Then correction of the fluid and electrolytes. So intravenous fluid administrations must do a catheterizations to monitor the urine output, because that urine output can dictate you what about the hydration status of the patient is, what is the color of the urine. That can dictate you what about the fluid is corrected. Parenteral broad-spectrum antibiotic given along with metronidazole, EZOLOY-PETIS, ceftriaxone, and metronidazole. Or previously we can press amoxicillin, gentamicin, and metronidazole. That three drugs can routinely practice previously. But nowadays we can practice ceftriaxone and metronidazole. And parenteral anti-ulcerant drug must give there. And parenteral analgesic, particularly non-narcotic analgesics. And monitoring the vital signs, urine output, etc. Pulse, blood pressure, etc. Monitor, urine output monitor, and fit for surgery, then go for surgery. That definitive treatment, surgical treatment done by laparotomy or by laparoscopy. Whatever the facilities available, you can do it. So laparotomy or laparoscopic repair of the perforation with thorough peritoneal toileting. That term must be complete. Otherwise, your answer is not complete. With thorough peritoneal toileting. That means you repair the perforation is sufficient to prevent further leak and heal the perforation. But what about the contamination? That contaminated materials must be removed out from the peritoneal cavity. Otherwise, there is a chance of residual abscess development. For that reason, their answer is laparotomy or laparoscopy, repair the perforation with thorough peritoneal toileting. Toileting done with the normal saline. Normal saline, you push the normal saline inside the peritoneal cavity, wash the peritoneal cavity, suck it out. Or in case of laparotomy, mopping the peritoneal cavity with the wet mop after normal saline wash. So dry the peritoneal cavity more. And what about the repair? So whenever there is a perforation, so that means there is a hole in the duodenum. So your aim to approximate the edges of the perforation. For that reason, you take a bite there. So whenever there is a bite, you make a tie there. So that tie causing sometimes cutting the tissues, because the tissue around the ulcer margin become friable. For that reason, we practice it Graham patch method. That means we take some stitches first there, don't tie it, open it, then put the omentum over the perforation, then make a tie. So whenever you tie the tie, there is a less chance to cut the tissue, because they interpose the omental tissue on the perforation side, and also advantage is the omentum is sealed the perforation more tightly. For that reason, the name of the operation is called the Graham patch method. And some surgeons, they choose like this way, it is called the modified Graham patch. That means they first tie the perforation, close approximate it, then over there they fix a omentum. it is less secured, it is more secured. So we practice usually a gram patch method. So look, there is a perforation, and 1, 2, 3 stitches, interrupt stitches taken first. Then place the momentum and make the tie. So it is gram patch methods. But another question sometimes asked in the postgraduate exam, so which stitches first you tied? Middle one or any of the end? The answer is both end first, then the middle one. Because the middle one is more wider, there is more tension for that reasons. So 3 stitches given, first the peripheral 2, lastly the middle stitches tied. So it is the question sometimes asked in the exam. But my practice is, this is so small hole there, I usually don't practice about the 3 stitches there, only 2 stitches sufficient. Because very small hole is 1 centimeter or less, so there is only the momentum is pushed there, place only 2 stitches sufficient to seal the wound. But in the book teaching, for the exam, your answer is 3 interrupted stitches taken first, then place the momentum and make the tie. So in case of gram patch, modified gram patch, look, they first given the stitches there. So approach to each others. Then over there, the momentum is placed over there and tied. It is called modified gram patch. So look, the laparoscopy view of the duodenal perforation, which is done by me in a private clinic. So look, these are the fibrinous exudate and also the contaminated food materials. So suck. So the body, this is a pelvic cavity. The side of the perforation, this is the perforation site. So take the stitches there. So momentum is placed there. And always the patient, nothing in mouth, nasogastric suctions in the postoperative period, at least 72 hours. And after toileting, you must give the drain in the various pockets like subdiaphragmatic space, the pelvic cavity, in the cutter. So some residual collection can escape out, so there is a less chance of residual abscess develop. So these are about the stomach and duodenal disease, the benign one. So what about the gastric outlet obstructions? So the gastric outlet obstruction presentations develop in various causes. Look the chart carefully. In case of pyloric stenosis due to chronic duodenal ulcer, it is the commonest one. The others are rare, but that things needed for your exam. It is called the congenital duodenal web. That means it is a mucosal fold, lies at the second part of the duodenum at the site of the ampulla of Bettel. So that duodenal membrane, they are having a central opening there. So it is a narrowed. It represented as a gastric outlet obstructions. For that reason, the cause of the gastric outlet obstruction is chronic congenital duodenal web. Another one is whenever a patient having an annular pancreas, so the pancreas is encircled the duodenum. The lumen is narrowed. Subsequently, the patient may have presented with a duodenal gastric outlet obstructions. Sometimes the patient may having some indigestive food materials, or the patient having a psychic patient, ingestion of the herbal. So subsequently it is accommodated in the stomach. The patient presented with the outlet obstructions by blocking the agents, which is called the bezoar. There are 2 types, trichobezoar and phytobezoar. So these also causing the gastric outlet obstructions. Or there is a true important thing is, which is most of the students don't give the answer, is complication of the gastric ulcers, like hourglass contracture and teapot deformity. That two things is very interesting one. I can elaborately describe in the next slide. It's a very important one, though it is not common, but may present as gastric outlet obstructions. So, in case of malignant disease carcinoma and trauma of the stomach, so enteral growth obtrude the lumen present as gastric outlet obstruction, or when the patient has carcinoma head of the pancreas, obstruct the duodenum presented as a gastric outlet obstruction, or in a duodenal malignancy may present as obstructed lumen and presented as gastric outlet obstructions. So, lot of causes are developed in case of gastric outlet obstructions. So, be remember that two things is mandatory. One is pyloric stenosis due to coronary ulcer, another one is carcinoma and trauma. That two things is first one. The others are rest is required for achieving the more mark, but that are not the common things. That are the rarest things. So look at this two picture. So hourglass contracture. This is the hourglass. That glass in the ancient time before discovering the watch, their time is calculated by pouring the sand in one chamber, and what amount of sand is passing down, this is calculated and the time is watched by marking here. It is called the hourglass contraction, narrow opening there. From one chamber to other chamber, when the sand is migrated, the time is watching in the ancient time. So the complications of the gastric ulcer, the stomach represent like this instrument. For that reason, it is called the hourglass contraction. This is very important thing is, the stomach is a big lumen. Usually don't develops the hourglass contracture or gastric ulcer causing the narrowing of the lumen marked. But whenever there is an ulcer in the greater curvature along the anterior wall and the posterior wall in a saddle shape, so both the ulcer when healed, the ulcer becomes cicatrized and narrowing of the lumen, so it converted into two parts, it looks like an hourglass. For that reason, it is called the hourglass contraction. That hourglass contracture, so there is a stomach, small stomach is there. Whenever the patient ingested, it does not go down, so there is presentation is vomiting. So the presented looks like a gastric outlet obstructions. So hourglass contracture develop in case of gastric ulcer, in that time may presented as a gastric outlet obstructions. So this is hourglass contracture. So another thing is a teapot deformity. It is also a very important thing one. So look at the teapot. So there is a two end, one is handle, another is the tip for pouring out the tea from there. So for that reason, the external pouring end is up, not in the down. If it is down, the tea is spontaneously expelled out. For that reason, for stay of the teapot end is up. So whenever the stomach is placed like that manner, so empty is easily. Whenever the ulcer along the lesser curvature, so that lesser curvature ulcer become healed, so ulceration healing, scarring, causing contraction. So at that time, the end of the stomach, that means duodenum end, is go up. So it does not empty properly. For that reason, the patient present to you as a gastric outlet obstruction. So teapot deformity causing gastric outlet obstruction. This is due to cicatrization, shortening of the lesser curvature. They present with the features of gastric outlet obstruction. So these are the cause of gastric outlet obstructions. Thank you, everybody. This is about the description about stomach and duodenal diseases. Now the session is open for question and answering session. Now the session is open for question and answer. So do you have any query or question? Please ask now.
Hello, Assalamu alaikum, sir.
Aslam.
Sir, I have a question, sir. After vagotomy, how hydrochloric acid is produced? And won't there be any problem if there is achlorhydria?
Yes, there is. Whenever there is a achlorhydria, there is a chance of subsequently malignancy. One. But in case of vagotomy, the other stimulus is there. In case of antrum, so there is a gastrin release. So only one factor is obliterated by releasing the vagus stimulations. So it is not the total achlorhydria there after doing the vagotomy. May I clear?
Yes, sir. We're just reducing the amount of hydrochloric acid only.
Yes.
Thank you, sir. Assalamu alaikum.
Aslam. So read from the books because it is a big chapter and all the time lot of question present in the written, in the long case, in the OSP. So any more?
Sir, Assalamu alaikum. Sir, we know in case of non-cooperative patient or other condition like shock patient, we in case of percutaneous feeding gastrostomy, we use general anesthesia. But in comatose patient and having shock, if you use the general anesthesia, it may worsen the recent condition. Such condition, we can use local anesthesia. And in this condition, like using local anesthesia, which precaution should we take?
For PEG, percutaneous gastrostomy?
Yes,
Or
yes sir.
For
percutaneous feeding gastrostomy, sir.
So in case of percutaneous gastrostomy, when the patient is not fit for general anesthesia, or only if you maintain the airway patency. So in that cases, the patient is not capable to fight with you. So you can do it easily with little effort. Because during give the anesthesia, the patient needs intubations and maintain some periods. So it is very difficult to give the anesthesia. So in that cases, sometimes some anesthesiologists may help with the only some, they can push some sedative drugs, IV sedations. So it helps to maintain the procedure very easily. But in case of PEG, percutaneous gastrostomy, it is very simple. Just put the endoscope through the mouth, inflate the stomach. So stomach is inflated, touches the parietal wall. So after touching the parietal wall, the light is seen from the exterior. So from outside, put a needle, the blood cell needle type needle, there's a trocar cannula, put inside the stomach directly. Through the stomach triangle, gastric triangle. So there is no viscera there. Directly enters the needle, look inside, throw the needle, remove the trocar, put a guide wire, and hold the guide wire with the endoscope, pull it out through the mouth, attach with the gastrostomy tubes, then again pull, throw the mouth, throw the stomach, go exterior directly. So very easily can done. Only small incision is needed to over the skin by local anesthesia. And the patient needs cooperations. So this is about
Yes, sir.
the procedure. Okay, thank you. Any more?
Yes, thank you, sir.
So thank you, everybody. Thank you for patient sharing. Our next presentation day after tomorrow night at 10 p.m. Okay, thank you.
Thank you, sir.